Hi everyone, I'm seeing a little tiny box in the top corner, so if I actually minimise this so I can see people. Is that right?
Yes.
I'll just minimise this, see if we can actually see you. No better. Okay. Alright. Alright, so can you give me some idea where you're from, where you're working? Need to unmute your speaker. Is anyone from up north?
Yeah, Susan Delaney, Fitzroy Crossing.
Good, okay, excellent.
You've got 4 of us from Derby Hospital.
Great.
I'm going to do that.
Please,
And
I don't know how to use it.
Bunbury Hospital.
okay, Carnarvon as well here?
Yeah.
Busselton Hospital.
Yeah, can you hear
Busselton, good.
Bunbury Hospital.
Okay, hi, Albany?
Steve from Warman.
Okay, good. Gee, we've got a good turnout, haven't we? Great. Okay. All right. This presentation is really, I'm thinking that you want to know more about gestational diabetes. We will talk a little bit about diabetes itself as well, but the main focus of this will be on gestational diabetes. I think most of you would manage gestational diabetes, with some perhaps type 2 women Australian in some areas. Bunbury, I know you do type 1. Anyone else? No. Okay, so everyone happy with honing in on gestational diabetes? Okay. All right. So we're talking about hyperglycaemia in pregnancy, which encompasses all types of diabetes that you're likely to come across in pregnancy. It is one of the most common health complications of pregnancy and is increasing. And certainly that's largely due to the fact that obesity is on the increase and that we're getting more people diagnosed with diabetes as well. And we'll talk a bit more about that down the track. The worldwide epidemic of type 2 is affecting more young people. We see a lot of women, as I'm sure you do, with type 2 diabetes, which you wouldn't have seen years ago. And so it means we've got younger and younger people developing type 2, so therefore that predisposes their babies to having type 2 down the track as well. And unfortunately, although we tend to have brought, not totally, but certainly helped to bring congenital malformations in type 1 into a better range of occurrence, we're seeing more and more people with type 2 with babies that have abnormalities. And I know from some of you guys up there, we get women referred down to us with those issues. This is the latest stats I could find on the Australian Bureau of Statistics website. In 2014 to 15, about 63.4% of Australians 18 years and over were overweight, 35% overweight, and 27.9% obese. And a lot more women living in the most disadvantaged areas are overweight or obese, and I think that's something that you would say as well. The rates of overweight and obesity do increase with age, but I was looking at the stats on there, and it says that between 2011-12 to 14-15, there actually was no significant increase in the rate of obesity, whereas from 2009 through to about 2011, it has been quite a significant increase. And I really found that quite interesting because I can't say I've particularly seen that. Anyway. Diabetes in 2014 to 15 represented about 5.1 of the Australian population had some type of diabetes, and this had increased from 4.5 in 2011 to 2012, and the actual numbers, I can tell you. 1 million people in 2014-15 had type 2, which was up from 840,000 in 2011 and 12. A further 158,900 people had type 1 in 2014-15, which was up from 113,400 people in 2011 to 12. So you can see type 1 has also increased, and that we do know. So diabetes is not going anywhere anytime soon. The proportion of diabetes in pregnancy that is type 2 now exceeds type 1. And GDM there is no doubt that GDM is a fastly growing type of diabetes. And NDSS data, which I happen to have privy to, I can't tell you how I got that, but I did. 2016 to 17, more than 37,000 women were diagnosed with GDM. That, I would suspect, is possibly understated, because I know women in remote areas very often are not registered on NDSS. You have S100 perhaps, and that NDSS data may be lower than it should be. Indigenous women are much more likely to have type 2, and they're 1.5 times more likely to have GDM as well. At King Edward, these are our latest statistics. I only got them this morning, in fact. We've been sitting on around about 20% of the women who deliver at this hospital have some type of diabetes. And that's been since January, which is just running us off our feet. So of the total number of women delivered in the first 3 months of this year, which was 1,438, 20%, just under 20%, it was 19.58% have any type of diabetes. And of those women, about 17.5% of them actually had pre-existing diabetes, and we do see more type 1s than we do type 2s. Generally that is about double, but it just depends a little bit. At the moment it's pretty much double. We're 80% with GDM stands to reason, and of these women, this includes the type 1s, 50% are on insulin, and another 9% on OHA'S that may be plus or minus insulin. So we run an ambulatory stabilisation program here, and we are constantly on the phone or on email to these women trying to sort out their blood sugar levels. So, challenges in providing antenatal care. Indigenous people are more likely to live in rural and remote areas, as you're all aware, and for those reasons resources can be limited. There needs to be good communication between specialist teams and primary health care in the community. And of course, telehealth is something we're using a lot now, and I'm sure most of you have been talking to Marina or aware of Marina and the referring into telehealth so that she can help manage women who live in the country without the need for them to travel down to see us. Certainly not all the time anyway. They come down at times we need them. So looking to the future, diabetes ranks highly on the international health agenda as a global pandemic and a threat to human health and global economies. It is predicted, I've heard this at a number of conferences, that there will soon be a country that's gross domestic product is less than the actual cost of diabetes. So 10 countries bankrupt. The prediction is that there will be 600 million people with diabetes by 2035 worldwide. And of course, as we've already said, there's a worrying feature is rapid increase in emergence of type 2 in young people. There's a fair bit of focus, which I'm sure you've heard of. We've been to any recent conferences. The last one here in Perth, the ADS-ADA. This did come up there as well, and it's certainly one of the hot topics, is the contribution of epigenetic mechanisms on and that effect on intrauterine environment. If you have any questions, please ask me. It's not meant to be totally didactic. I want to know what you want. Okay, everyone okay? Okay, so epigenetics, does diabetes originate in fetal life? There's a fair bit of thought now that this certainly plays a big part. And these were way back years ago when I first went to a conference, not when I first went to a conference, but one of the conferences I did go to years ago. This came up then, and as you can see, these references from 2005. So we thought then intrauterine exposure to hyperglycaemia may cause obesity and insulin resistance in childhood, followed by impaired glucose tolerance in type 2 in adulthood. And that, again, there's a strong association between intrauterine exposure to diabetes in pregnancy with obesity type 2 in adolescents. And they thought then that 47.2% of type 2 was explained by this exposure. This comes from Lancet, and this was from a conference, I can't remember which one it was now, it went to in 2013. And it did talk more about the epigenetics and developmental origins of type 2. So epigenetic modifications defined as heritable changes that are associated with changes in DNA sequence. Sorry, that are not associated with changes in DNA sequence. And in the last decade, epigenetic pathways in early life events have received substantial attention, as we already know. And one example is, and there are others, babies exposed to famine situations in utero have worse glucose tolerance. And one of those examples is the Dutch winter famine in late World War II, where the Germans actually prevented food entering a part of Holland, and the people there actually starved. So what they've done is they've followed up the children that were born during that famine or just after that famine, and 6 decades later they found that DNA changes are still evident. So we know that these changes are transmitted through future generations. So when you're going from a situation where you've got starvation to a situation of plenty, and that woman is pregnant in that situation of starvation, then that child will have problems coping with the change in the environment. So put it succinctly, if you like, a pregnant woman programs her fetus for the metabolic world in which she lives, and which is expected her child will live. And these messages are passed down through many generations. All right. So what is gestational? Any questions so far? Right, save it to the end. What is gestational diabetes? It's a carbohydrate intolerance. It's a day definition of variable severity, first recognised in the current pregnancy and which goes away after delivery. You'd all be aware by now that screening for gestational diabetes changed about nearly 3 years ago now, I think, and has been endorsed by Ranscog, who these changes took us from a fasting level of 5.5 down to equal to or greater than 5.1. A 1 hour level was introduced, equal to or greater than 10, and a 2 hour level equal to or greater than 8.5, which actually was a rise. And I don't know whether it's from this or whether it's just increased, but we're certainly seeing a lot of GDMs. Diabetes and pregnancy, problems that are associated with that. We have insulin resistance occurring in pregnancy, which can occur for many reasons. We all are insulin resistant to some extent. More insulin is produced during pregnancy because of the changes going on, because of the number of hormones that are actually produced, and there's a greater need for insulin to overcome this. There's risk in pregnancy of preeclampsia, polyhydramnios, fetal macrosomia, and birth trauma. They're more likely to have an operative delivery, whether that be forceps or cesarean section. There's a greater risk of perinatal mortality, and of course neonatal metabolic complications, and a bit of a stint in our nursery. So GDM in the community, all women require education to be able to manage their diabetes. Women are invited to attend a 2-hour group session with the diabetes educator and dietitian. And they are asked to monitor their blood sugar levels ongoing at specific times, which we'll talk about in a minute. Blood sugars are reviewed at each antenatal visit, but what we actually do here now is, if a woman is on diet only, the dietitians actually manage the blood sugar levels, So the woman is requested, and we give them a generic email address to send their blood sugar through to the dietitians at least once a week, and the dietitian will review that, make changes if necessary, and if they're concerned, they'll contact the diabetes educators to take further measures to perhaps start insulin. So because of the sheer numbers, we've had to work it that way, so the dietitians take a fair proportion, and I take my hat off to them for that, because it is a big job for them as well. They see other women with other things in the hospital that we just have so many. Women who are on insulin, women who need to start insulin then come under the auspices, if you like, of the diabetes educators. So we bring them through to us. They are then given a generic email address to us and asked to contact us on a regular basis, usually a couple of times a week, and we talk to them either by email, but very often ringing them then to find out what is actually happening, about what they're doing and how they're doing it, and if necessary, we'll start insulin. Once they start insulin, then the contact becomes more intensive. The best management for any type of diabetes is certainly a multidisciplinary team. As you can see, with the GDMs, the dietitians and the educators work well together. With commencing insulin, we also include the physicians, and a lot of those women will actually come to our clinics, not necessarily because they're on insulin, but because they're either diagnosed early or there's something else going on. But we do not see through the diabetes clinics every woman with GDM who comes to the hospital. We do see all of the type 1s and 2s, but the women with GDM are spread throughout the other clinics as well, with the ones who are much more likely to be high risk coming through to either Marina's nurse practitioner GDM clinic or through to one of the diabetes multidisciplinary teams. They have regular antenatal reviews. We do actually have a flow chart, which is you're welcome to get if you wish. I don't know whether you can see this or not. I'll be able to see it, will I?
Yeah. Or I can email it to them.
All right. This is the management chart which we have. It's actually for type 1, type 2 and GDM. You're welcome to a copy if you'd like to use it to help with your regulating your women. Remembering some of it is quite intensive because we're talking about type 1 here as well, so you need to take what you want from it. But it is useful, tells you when an anatomy scan should be done, when fetal monitoring testing should be started and so on, and also a fair bit about antenatal, just general antenatal education, not necessarily diabetes education. It's a medical record chart number, so you can order it as well. We are going to review that. There'll probably be things in there we will change, particularly the frequency of ultrasounds, because we're getting a bit, or at least we're not, but ultrasounds getting a bit overwhelmed, I think. So we may look at some changes in some parts of it. Women have regular fetal assessments, so that's regular ultrasounds and fetal monitoring, particularly if they're type 1 or 2, particularly if you're on insulin. For all our pre-existing diabetes women, we do a check to see how they're managing their diabetes, what they've been on, if they know what they're doing, and also they should have a complication screen, particularly an eye review, very important in pregnancy, because if they have any eye problems, even if they don't, their eyes can deteriorate pretty rapidly. Medication review, again, what they're on. If they're on OHA'S, as a type 2, then that needs review. Do we keep it or do we not? And most of them we do not. And for insulin, of course, that's going to be looking at starting it and titrating that. And as I said before, we have an ambulatory stabilisation program, which the educators run, and we do most of that. So monitoring blood glucose, this is what we do at the moment. When the criteria first changed, we tried to look at whether we could work out how we would manage these women. And one of those things we were looking at was to see whether women should be testing at 1 hour or 2 hours for their blood sugar level. It's a bit hard to get women to test any more frequently than about 4 times a day. If you're looking at it before breakfast, then either a 1 or a 2 hour post-prandial blood sugar level It didn't really work out well for us to do that. What we do now is we actually do before breakfast and 2 hours postprandial, regardless of what the GCP is on that 1 hour, given that it is now a reading that is taken note of. Having said that, it is hard to know if you've got someone with a normal fasting and, say, an 8.6 or something at 2 hours, but a 1 hour that's up in the 14s, not to want to know what that 1 hour is doing. At this point, if someone can correct me, I'm not aware of any particular guideline that actually tells us really what to do about this. The fasting level also is another one that we've had a few headaches over. You need to remember when women are testing blood sugar levels at home that there is a range difference in what the meters read, and I've always taught that it's acceptable for a meter to be 0.5 either way. It will be okay in its readings. They're not precision meters. They will have a reference range that can do anything. So someone with a blood sugar of 5 may actually only have a blood sugar of 4.6 or something. So if you're going to start insulin on that, you're risking pushing women down. Having spoken to quite a few people from interstate, we've actually sort of come to the conclusion that 5.3, and this is what most centres seem to be using, would be a good cut-off for starting insulin. But it's still very individual, and some centres are doing it differently. Women are asked to monitor at least 2 or 3 days a week, and most of them will do it virtually every day, but we at least ask that. So, diet, important part of managing these women. Certainly whether they've got type 1 or GDM, they still need to make sure that they're eating properly. And we use the Australian Guide to Healthy Eating, basically, but the dietitians will always review these women and teach them about the amount of carbohydrate they should be eating. And we try to hone in on a diet that's fairly high in proteins and not too much carbohydrate, and plenty of vegetables or free vegetables, along with their dairy products. So women are taught what are carbohydrates, and the ones circled you can see are the foods which do have carbohydrate in them. And so they're taught what to use, how much of that to use, and how to divide up their plates. I'm sure all of you are fairly familiar with diet and diabetes and what's what. It's about balance, and as you can see, a huge meal like the one on the right will cause blood sugar levels to go up, whereas a pasta meal with like the one on the left with added vegetables which are free, then that may also give her good blood sugar levels. And the goals are basically that diet should be the cornerstone of treatment, it always should be, that you're aiming to obtain normal blood glucose levels, whether they're on insulin or not, that they are regularly monitoring their blood sugar levels, the diet is balanced, they're getting enough pregnancy vitamins and minerals, and that weight gain or weight maintenance is within range. Any questions open up? No? Okay. All right, let's look at medications. The gold standard, I guess, if you like, is insulin therapy. Certainly all of our type 1s come with this. What regime they're on generally remains depending, unless they're on something like Novamix or one of the other mixed regimes, we might change that out, but most type 1s these days are not. And of course many type 1s are on pumps, and although we don't actually initiate pumps as such, we don't start them at King Edward. Many of our women come from other hospitals on them, and if they start them in pregnancy, that's normally done elsewhere as well. We ask all women to self-administer their insulin. Some women can be needle phobic, I'm sure you know, but with gentle persuasion often you can get around that, but sometimes it's not easy. Oral hypoglycaemic agents. It depends who you talk to as what answer you get about this. But anyway, metformin is, as you know, the NIC trial is still on, or the follow-up to the NIC trial is still on. I'm not sure where they're at the moment. I think it's around about 10 years old. It could be a bit older even. It's being used more often in pregnancy. It is believed to be safe through the trial, but the long-term follow-up is what we're now looking at. I was talking to Dorothy Gray the other day. She seems to think there's some adverse findings in some of the trials that are currently come out, but I honestly don't know what they are. It is very useful to overcome insulin resistance, purely because of its action. And when you have women on 100 units of insulin 4 times a day, using metformin is very often what we would do to try and get that dose down, because that is really a lot of insulin. Developmental has until recently been in our protocol for use, but we have taken that out. The latest literature on that is saying it's not safe for the fetus. We do know it crosses, and it can cause problems for the baby. The baby, the infant of a diabetic mother, problems that can happen now. This is all related to the fact that when the mother has high blood sugar levels, high blood sugar levels cross to the baby very freely because the baby needs that for its own energy use. But if the mother has high sugar levels, then the extra also crosses. This forces the baby then to make extra insulin, so its pancreas or its beta cells become overactive. They enlarge, and you get this production of insulin continuing on, which basically continues to drip out, if you like. Insulin's a growth hormone, so you get big babies, and other problems, metabolic problems that go with that, such as hypoglycaemia. They're more likely to be jaundiced after delivery. They're more likely to have a reduction in trace elements like calcium. They're also polycythemic with that growth in red blood cells. And respiratory distress is quite common as well. When you have big babies, macrosomia babies, you are more likely to have birth trauma, and that's something to be considered for delivery. Of course, stillbirth and neonatal deaths still do happen. And we still see quite a lot of preterm babies. So macrosomia is defined as a birth weight for gestation, which is above the 90th percentile. As I said, it's supply of glucose from the fetus to the mother and insulin production by the fetus, and the fetus grows larger under the influence of glucose and insulin. There is your macrosomic baby, pretty typical. You can see the vertex on it, you can see the hair, you can see the fat cheeks, the layers of fat around. That is the sort of baby you don't really want to see, and if they do, they're going to need specialist care. There's an example of a normal sized baby and a very big baby. And on here we've got a little pretermer on the left, and the one on the right is an IEGR baby, a baby that's small for gestational age and undernourished in utero. So that this little baby, the one on the right, stands a good chance of getting diabetes in the future. It's one of those babies that's been starved in utero and is born into a world where it'll probably get more food than it really needs, or is used to, if you like. Breastfeeding and diabetes. There's a fair bit of literature around now that states that breastfeeding can help prevent diabetes in the mother, but also in the baby. And it also assists in weight loss in the mother, but women should be encouraged to breastfeed as long as they possibly can. So there should be no limit on that. They should be breastfeeding for as long as they can. There are studies around that say it's protective against type 1. There were studies around that said that formula feed, or particularly cow's milk, could cause type 1 by producing antibodies. There's been a couple of studies about that. And for these reasons with breastfeeding, we actually do encourage our type 1 women at this stage, and this is now becoming, as growing momentum now since the Dane study came out showing that expressing breast milk and giving it to these babies in those first hours of life rather than giving them formula or anything else is protective for those babies, and of course it does increase the blood sugar levels much better than formula will. So it's important to encourage women to breastfeed as long as they can, get those babies to the breast as soon as possible. So when the baby's born, it should receive skin to skin, and it should be kept warm, because if the baby gets cold, it will lose glucose levels, will drop. And it's really important that these babies start feeding as soon as possible. Well, any baby really, but certainly these for that reason. So, are there any questions?
You got it? Yeah. Hello?
Hi.
Hello?
Hello, can you hear us?
Yes. Hello, yes, we can hear you. Oh, no,
Okay,
where's she
yeah.
gone? Just asking if it's possible for you to email the charts, the programs you have, the ambulatory stabilisation program, the flow chart from King Edward, and the complication screening chart to Bunbury, please.
Yeah.
Is that
okay?
possible?
Because the complication screening is on here, it's basically saying check the eyes, check reflexes, check all those sorts of things. Okay, but I can send you the ambulatory stabilisation one.
Yes, yeah. Yes, and the flow chart.
Would you like me to send this to Wendy?
You can send it to Wendy, or you can send it to Andrea.
Drew.
Andrea Drew.
Maternity.
In maternity at Bunbury Regional.
Drew, D-R-E-W?
Yes.
Could you just send it to all the sites that are on the BC?
Yeah, okay, that'll probably be easier.
The diabetic educators may have it, but I just think we should have it on the board.
I'm just trying to bring you up.
Yeah, we can't see
Yeah,
it.
we can't see you either.
Hang on, I'll just get this thing to work.
None of us are proficient with it, so sorry.
Oh, no, so
And I ain't got any, tell her I ain't got any, it's just the die. That's all right, I can't see again.
Put it in the wet.
Oh, there we are. We are.
There you go. Can you see me?
Yes.
Yeah.
Yes. Oh, good. Okay. That's better. I can see faces. Okay, I'll get these guys to send up everywhere the charts. So you want the ambulatory stabilisation one? We can do that. And the management flow chart, which is this one, send that. That has information about what to check, looking at eyes and looking at feet and looking at reflexes and so on.
Okay, great. Thank you.
Hi, I've got a question, if that's okay.
That's okay.
Can you hear me? Yeah, it's Jenna here. I'm calling from Buckingham. I'm a student midwife.
That Heidi.
Okay. One of my questions is, you were saying that there can be congenital abnormalities with babies born with diabetes. Is that just which type of diabetes? Is that for all types, including gestational diabetes? And if so, what kind of congenital abnormalities occur?
Which Gemma?
No, gestational diabetes is not a when the congenital abnormalities occur in the very early weeks of formation of the baby, so you're talking probably less than 6 weeks, but certainly no more than about 10 weeks. So a type 1 or a type 2 who's had poor diabetes control in that time is very likely to have a baby with an abnormality, and that can be across the board. The most common ones are things like heart defects, spina bifida, so neural cord defects, things like anencephaly, other things which are more likely. But heart defects we see a fair bit. We don't see that much spina bifida, maybe that's because of folate, but certainly we do see them. And it can be anything, kidney problems as well. GDM, because GDM is diagnosed later in the pregnancy, it's not associated with that risk. Yes,
Sorry.
Damien.
Yes. So, Emily, you mentioned that diabetes contributes to polycythemia in the neonate. Do you know what the pathophysiology is at? Like, why do we see more plethoric neonates with a diabetic mother?
Well, it's to do again with the growth, the excessive growth that's going on, and that includes red blood cells. So because you've got that increase in red blood cells, they can develop polycythemia. They also can develop jaundice because that takes time for that to break down, and of course that's your end result of that. So it's all to do with that hyperinsulinemia, so extra insulin running around the blood, which causes the growth to happen in all areas. Yeah.
Sorry, Di, can I please ask, can you supply me more information about the complications of metformin in pregnancy?
Oh, okay.
Or give us the link to that article.
Sorry, say again?
The link to that article.
Or maybe give us the link to that article in the New England Journal.
Oh, okay. Yeah, that's on the slide, I think, isn't it?
Yeah.
There's and you're getting a copy of the slides too, incidentally. The MIG trial, you can go online and have a look for that if you wish. That was the one done in New Zealand, but there were quite a lot of hospitals in Australia that were part of that, including King Edward. It was done years ago now. It has to be 15 years ago, I think. It showed that the idea was to see if metformin was safe. And it did show that it probably was, and it is certainly a very useful drug, especially in type 2 and UEN because of insulin resistance and all the rest of it anyway. It's more to do with the follow-up of the babies that they've done. So they're looking at all the children that were part of that study and looking to see if down the track there are any adverse outcomes to that. What I've heard so far is that some children are bigger. They have they're more obese. Not obese, I shouldn't say that. Their weight is heavier than what the counterparts are, and there's still a fair bit of doubt about whether it's something that will cause problems down the track. We really don't know. Physicians vary with what they will use. We have a physician who just will not use it at all. She is just totally against it. We have another physician who will. I actually think it does have its place. I actually think that if a woman is on huge amounts of insulin or is very highly insulin resistant, the metformin plays a big part in helping to prevent that or helping to overcome that. But I think it needs to be used with caution.
Okay, and have you got any, or do you, King Edward, have any preference to metformin XR or just normal metformin?
Usually normal metformin. We do get women coming in on XR, but they tend to be switched over.
Okay. And for what reason?
Just another new drug, I think. Yeah. Possibly. Okay. Yeah. So it again, it depends very much on the physician. Many women are actually stopped often even by the GP before they get to us.
Yep. Okay. Thank you.
Sulfonylureas, there really isn't anything. Lebenkilamide in the Lanier study years ago came back at saying it was safe and what didn't cross the placenta, but we do know from more recent studies it does, and that can cause problems with babies.
Yep. Thank you.
It's actually used in MODI. Have you guys heard of MODI? Mature onset diabetes of the young?
Yep.
Yeah. There's certain types of MODI where, and there's about 14 of them, where you use, Dr. Savanthi uses this in MODI, but she's quite keen on, she's quite an expert on MODI in fact, but lebenkilamide is useful in treating blood sugars in certain genetic arms of MODI. And the only way to know that really is by looking at your baby. So if you're treating a MODI with insulin, you've got a small baby, then that baby needs to come off the insulin. There's quite a lot to this, and it's well worth, if you ever get a chance to listen to a talk on MODI, have a listen to it, especially in pregnancy.
Thank you.
Sorry? Did someone say something? No? You turn your mic on if you haven't. No? Anyone else?
Can you please, Kate in Derby, can you please explain what's MODIC or MOBIC or whatever you're talking about?
MODI, mature onset diabetes of the young, it's called. MODI.
Ah, thank you.
It's we used to see it years ago. We used to think it was just young people with diabetes, we called them MODI, but we know now it's quite different. It's something that runs in families very strongly, and there is a genetic inheritance for it. So it's actually one of these hybrid, along with LADA, types of diabetes that you get. Have you heard of LADA? Latent onset diabetes of the adult. So it's someone who's got type 1, but it gets it later, or at least we treat it as type 1. So someone over the age of 35 who develops what we think is type 1 is more likely to be LADA, latent onset diabetes. Latent adult onset diabetes, yeah.
Bentley here, I have a question as well. In regards to epigenetics now becoming a big predictor for diabetes, is a woman who declares a family history of diabetes enough of a reason to warrant an early GTT?
Sorry, you'll have to say that one again, you're breaking up.
Oh, that's okay. I was just saying, with epigenetics being a big risk factor for GDM,
yeah.
Would a woman who presents with a family history of diabetes, is that enough of a reason to warrant an early GTT?
Oh yeah, absolutely. Epigenetics is more related to type 2, but certainly the development of type 2, particularly in young people and as they get older. GDM is part of that, I guess, but it's certainly more related to type 2 in these studies that have been done. But any woman who has a family history of type 2 or even type 1 in their family should have an early GTT.
Okay, so does that even include if their mother or father's developed it in their 60s, that kind of thing?
Yeah, any history like that they should have. And if the woman, if the girl is overweight, if she's Indigenous or comes from other high-risk countries, for instance, like some of our refugees do, or immigrants do, she's had previous GDM, I say family history, PCOS, any of those things, a GTT should be done. It's pretty much one of those things you're going to do.
Okay,
but
thank you.
Higher risk, you do it early.
How early? Oh, so how early would you do that? Would it be at booking or 24 weeks?
No, by about 18 weeks if it's got to be done early. So if you've got someone with those sorts of risks, you should do one by 18 weeks. If that's normal, it's repeated again at 26 weeks, 28 weeks.
Okay, thank you for that.
Di, can I just ask, if you were doing a HbA, so if someone had GDM and you were doing a 6-week postnatal, or no, so if you did a 12-week postnatal HbA1c, so it's 3 months, is that diagnostic if it's greater than 6.5?
Not a HbA1c, no. No, you shouldn't be doing HbA1c anyway. It should be a GTT.
Yes, that's true.
Yeah. So
yes.
In general diabetes, the HbA1c needs to be up above, I think, 7.5 for diagnosis, and even then it should be repeated. There's lots of things that affect HbA1c. If a woman's anemic, for instance, if she's got iron deficiency anemia, she will have a higher HbA1c. So it's not a test that's totally reliable, nor is a glucose tolerance test for that matter, but it's still probably the better test to do.
Yeah. Thank you.
And when you send their women off to do GTTs postnatally, is everyone doing that? It's not that well known, I think, out in GP land. And I suppose one of the reasons for that is probably not in the country so much, but certainly in Perth, women GPs shop. So they get around, it doesn't happen. Any other questions? Can be about type 1 or type 2 if you wish, doesn't matter.
So you were saying it was essential for people with type 1 and type 2 to have an eye test during their pregnancy. That's because of the diabetic retinopathy?
Yeah. Need to make sure it's not there, and if it is that it's treated in pregnancy. Very important. Because pregnancy will exacerbate it, and we've had a couple of women go blind through pregnancy.
Yeah, thanks.
There's actually, are you coming to, any of you guys coming to our study day in a few weeks, the one in May? We've got a diabetes study day on. No? You're going to miss out on a very good talk. We've got Dr. Chandra from Royal Perth coming in to talk about OHA'S management. And I actually saw him at the ADS-ADA conference. If any of you went to that, he did a breakfast session and it was brilliant, absolutely brilliant. So if you want to come, book in. We may be able to get him back for the next one as well with a bit of luck, we'll see. Okay, is that it?
I've got a question. Can I ask a question about GTTs, please?
Yeah,
What's
sure.
What's the latest in pregnancy that you should be doing them?
You can do them at any stage. Obviously, if you're doing it at 38 weeks, there's really not a lot of point, but we get them with women having had them done at 35, 36 weeks for sure. And again, even then, it's hard because very often it's done because there's a big baby on board and someone thought, oh, we better check this out. And there's not a lot you can do then, but you might get a couple of weeks in of good management. So I think about that level would be 36 probably. After that, there's not a lot of
36 would be a cut-off?
Yeah.
Okay.
But that will vary.
All right.
Doctors.
So 36 would be your cut-off for doing the GTT?
Absolutely, but it should be way before that.
Okay. I have another question about a GTT. Just as a bit of a strange one this morning, we've got a girl that's just had one. So her fasting was 4.3. Her 1 hour was 11.1, and her 2 hour was 11.3. Can you tell me, apart from pathology error, how unusual is it for the second hour one to go up instead of down?
It always does happen. So her 1 hour was 11.1 and her 2 hours was 11.3, is that right?
Yes.
Yeah, no, that's fine. We do see that. Remembering again that, yeah, you do see that. You just have to accept it as it is. The only time I've ever questioned the laboratory one is when it's definitely off the scale or something. And I've had 2 or 3 over the years where I've actually rung the laboratory and said, "Are you sure you've got the right person?" Because it does not fit when I've got it in front of me.
I have just rung them waiting for an answer, but if you've seen it before, okay.
Yeah, I've seen that before, yeah.
All right, thank you.
Okay. So happy? Get this meeting here. All right.
Thanks, Di, that was good.
You say thank you.
Thank you.
Thank you.
Thank you.
Thank you.
Call us if you need any help or want anything. We're there most days. I wouldn't say we're there on weekends. Please ring us though if you're concerned. We're always ready to help. And don't forget Marina, you can refer to her to talk to patients via telehealth. Thank you all.
Thank you.